This episode is brought to you by the Society of Physician Entrepreneurs. The Society of Physician Entrepreneurs, or SOAP, is a global biomedical and healthcare innovation network with membership open to all healthcare professionals, entrepreneurs, and industry stakeholders. SOAP's peer-to-peer network empowers entrepreneurs by providing the education, connections, experience, and funding opportunities necessary to commercialize ideas, inventions, and discoveries. To learn more, please visit www.soapnet.org.
You're listening to the Indie Docs podcast, where we discuss important issues related to our mission to preserve, promote, and protect the practice of independent medicine. Thank you for tuning in.
Welcome to the Indie Docs podcast. Thank you for joining us. A quick disclaimer, we're sharing our personal opinions based on our own experiences, and nothing should be taken as professional legal, financial, or medical advice. I'd like to welcome our guest, Dr. Ronen Elefant. Dr. Elefant is the founder and medical director of ACES National Surgical Team and has a very unique model, which we're going to be discussing at length. He is a published author, an established and experienced surgeon, and an entrepreneur. So welcome, Ronen, and thank you for joining us.
Thank you for having me.
It's great to have you. Why don't we just start off by telling us a little bit about your path from traditional surgical practice to founding ACES?
Sure. So the idea of ACES actually came about many years ago. I was still in residency, and I had a particular interest in economics in general and healthcare economics in particular. It was right about the time that Obamacare came out, and things didn't sit well with me about what that was doing to healthcare. And I was just reading up a lot about the case against it and really why this was not a good solution to our healthcare problems. And I actually gave my Chief Grand Rounds talk about healthcare economics. It was cleverly named The Elephant in the Room, Why Big Government is Bad for Your Health.
And just to interject for those, our listeners who haven't looked at the print, your last name is Elefant, and you were speaking about the Elepphant, right?
Right. That name always comes in handy with play on words. So what brought the idea about was in researching the topic for my talk, I stumbled upon the Surgery Center of Oklahoma. And for those who are unfamiliar, Surgery Center of Oklahoma was the first center in the United States, freestanding ambulatory surgery center to offer transparent bundled pricing for surgery. They did not take insurance from day one, and they believed that most of the problems with our out of control healthcare costs are related to insurance. And based on all my research, that was pointing to the same problem. In fact, I think that what patients and physicians are frustrated with in medicine can all be traced back to the way we pay for healthcare.
Can you expand on that just a little bit? Again, most of our listeners are probably physicians, but what specifically are you referring to in terms of who's accountable for paying and who's making the decisions? But what specifically about this problem is leading you towards ACES?
Yeah, so, something as simple as like prior authorization, right? People feel like they pay into insurance and they feel entitled to certain services. The doctor feels that certain services are warranted, but neither the purchaser of insurance, who is the patient, or the provider of the care, which is the doctor, have much say in what actually happens in that interaction because we have this convoluted system of payment, right? So for any other good or service that we have, we pay out of pocket for what we want based on our own individual choices, and we choose where to spend our money. That does not happen in healthcare, right? We're told which providers are in network, which providers are out of network. Physicians are told what they can order, or what they can provide or what surgery they're allowed to do or what they're not allowed to do. Physicians do not get paid for months, or they may not get paid at all because they coded something differently, right? Or erroneously. And even the fact that we use like an electronic medical record, Keith Smith of the Surgery Center of Oklahoma said this, that like in a free market, nobody would have come up with the idea of an electronic medical record, or it's not necessary. And the truth is that the reason why it's ubiquitous is in order to extract as much payment as possible. It's built to satisfy the needs of the insurance company. It's not built for what it was originally touted as, which is like ease of use of finding out a patient's history,
Right.
and ease of use of ordering things. It's really geared towards making sure you use the right language so that you get paid for the services that you provide. In our model, all that goes away. In fact, at the Surgery Center of Oklahoma, there's only paper charts the way it used to be.
Right.
And the care is fantastic, and the cost is cheap compared to everything else. People may think, oh, you have to pay out of pocket, it's really expensive. No, the truth is that healthcare is so expensive because we're using a third-party payment system and insurance. But when you pay out of pocket for routine things, it's actually very affordable. And so the idea for ACES came about as a model from the Surgery Center of Oklahoma. I wanted to do a very similar thing. And for many years, I was trying to rack my brain around, okay, how do I do this in my home state, which was not a very favorable state to do it in because of multiple reasons, including like certificate of need and the politics within the state. But I came to the realization that instead of a hardware problem where I have to build another ASC, there's already a lot of ambulatory surgery centers out there. We can use the existing ones that are not at capacity and offer a similar model where we have direct, transparent prices. And that's what we charge the patient. And we just, pay the facility, pay anesthesia, pay all the players that are actually involved in the care, and keep insurance out. And patients love it because they get the care they feel they're paying for. It's a concierge level type of transaction. In fact, when we do surgery on any patient, they get our cell phone number. They're welcome to text us. They send us pictures of the wounds or text us if they have any issues or if they need a refill. And they feel like they're getting value for what they're paying for. Whereas with traditional insurance, again, on both ends of the spectrum for both patients and physicians, they don't feel like the value is there.
We'll talk about a little bit about the actual care part of things, but when was the moment that you realized that I need to own a plane and fly to my patients rather than, have them come to me?
So that really didn't come about as a result of this idea that I wanted to build ACES. So I became a pilot at the age of 19, and I flew couple hundred hours through medical school. Obviously, in medical school and fellowship, I didn't have a lot of time to fly. But when I got out of fellowship, there were a couple months before I was going to start my full-time job. And so I took on a locums job, which is basically just moonlighting. And I wanted to get back into flying. So I went with an instructor, rented a plane, and he would fly me to the jobs that I would have doing locums. And that's how I regained my proficiency in flying. Even after I started my full-time job, I really enjoyed the moonlighting gig so much that I wanted to continue to do it. You come out of fellowship, you're working 120 hours a week. All of a sudden you're an attending, but you're only working maybe 50 hours a week. So you feel like you have all the time in the world. You're hungry to do cases. You're not operating as much. And when I went to these rural hospitals to work doing the moonlighting, I felt like I was appreciated. I felt like I didn't have to deal with the local politics. I came in, I practiced medicine the way I wanted to, and I left. And so for all those reasons, it was very rewarding. And I continued to do that about 3 or 4 days a month in addition to my full-time job. And then I realized that I love the flying aspect as well. I would go all over the East Coast. I went to Florida, South Carolina, New York, Philadelphia, Maine. And I flew to all these places. I ended up buying my first plane in 2014, about 6 months after I finished my fellowship. And I continued to do that for years. And so flying became an integral part of my life and my work. In fact, one of the places that I was moonlighting at, I stayed at permanently, and it was always a flight away from home. And so I've been doing that for about 8 years in Pennsylvania. And so the idea to use an airplane to go to other facilities and other ASCs as part of ACES was not very different than what I was already doing. It was just a different practice model, right? So at the hospital that I work, I provide trauma coverage and emergency general surgery, whereas with ACES, we do elective surgery at ASCs.
So that was actually one of the things I was going to ask is how is ACES different from a locums agency or a quote traveling surgeon kind of gig like you mentioned?
So essentially it's the same, except for the fact that we do direct surgical care.
So your customer is who specifically?
So our customers are either patients who have high deductibles or are not insured, or employers who are self-funded and shop around for surgical services for their employees and their families.
And then do you work at hospitals or are these freestanding ASCs through ACES?
So for now, we're just at freestanding ASCs. We have been in touch with one small hospital, almost like a critical access hospital. That's about a 25-bed hospital that is functioning essentially as an ambulatory surgery center, and we may partner with them. The interesting thing is they were recently purchased out of bankruptcy by the group that we're in touch with who wanted to work with us. And they said that the reason why they went into bankruptcy was because of insurance, right? So because of traditional insurance that just doesn't pay the bills. And so they are very interested in our model because the truth is that we can do things for cheaper at a higher quality where all the players that need to be making money to run the operation should be making the money, whereas all the people that are sort of sifting off the top and not adding value are excluded.
So it's interesting. I mean, that actually made me think that indirectly, this might turn out to be a solution or an alternative for some of the problems that rural areas are facing, right? So a lot of the rural hospitals financially can't make it for a lot of issues that have to do with just being a hospital, whether it's insurance or not, but just the way hospitals are tend to be structured financially nowadays. But this may actually be a way to provide care to a rural area that might be deficient either in labor, right? Don't have a surgeon, or give a small hospital, like you just mentioned, an opportunity to actually use their facility in a way that would be financially more advantageous.
Correct.
So are you flying mostly to rural areas, or is it a combination? Or tell me how that landscape looks.
A combination. So, as a trauma surgeon, I fly into a fairly rural area in Pennsylvania. When we started ACES, and I'll actually take a step back, but what you're mentioning is actually something that I wanted to do as an expansion and informally have like an ACES outpatient division, which would operate at ASCs, and an ACES inpatient division, which would operate at rural hospitals, because we do have a unique advantage of being able to provide surgical services or even any medical services to rural areas where we can find physicians who would normally not be attracted to those areas and say, look, you don't have to compromise where you want to live if you're willing to work out of town for a certain number of days. And they can have a choice as to how much time they want to spend away from home working in these areas, but it's a very rewarding type of practice. And again, if they choose to live in a very urban area, they can, and we can bring them to facilities that would otherwise be underserved or would not attract the best talent.
Yeah, I mean, that's really an interesting kind of alternative version of your original model that when you just mentioned that, I mean, I thought, gosh, that potentially for rural areas may be a really attractive thing, not only because the labor force is hard to come by, right? The workforce, physicians don't necessarily think of going back to an rural area, unless they're from a rural area, they don't tend to locate or relocate to rural areas.
Yeah, so even in the ACES outpatient, ASC world, we just had a conversation today with a healthcare marketplace that told us that they love our model and that they have a need in the northern part of the Midwest. And again, it's very easy for us. Like, we're not a company that has to build a new ASC. We would just have to locate an ASC within the geographic area where the patients are and say, okay, if there's enough business in that area, we will send a surgeon out to the local ASC and do a certain number of cases over a day or two every month
Sure.
in all these rural areas. And the truth is, like, a lot of people are already traveling to places like the Surgery Center of Oklahoma. Since they started, there's probably another 5 or 6 centers across the US, and actually mostly in the Midwest and West Coast. There aren't really any facilities like that on the East Coast, but a lot of these patients have been traveling to those locations. We flipped the script. Now you don't have to fly down, spend a couple days, at a hotel to recover and all that stuff. We can do that where the patients are.
Right.
So we bring care back home.
And again, going back to the rural case model, which I really think would be a real boon for some of these rural hospitals, that even for them to be able to keep the revenue there, right? Rather than have those patients travel to a major medical center or another big hospital somewhere else, or if they don't have an ASC in the community. And that just seems like a really great idea. I mean, a real innovative way to address a problem that everybody's talking about. For sure in South Carolina, the rural healthcare is very high on the list, and as you know, there's a gigantic number of federal dollars being allocated to each state now to address rural healthcare. So this might be a real important piece of providing care to those areas that it's hard to come up with actually solutions, right? It's not that easy to convince people to move to a very rural area or to build an ASC or an endoscopy center or whatever. That's very interesting to me. I've read some of the things that you've written and some of the things that you've alluded to, are obviously very informed by Austrian economics, right? And both of us are fans of. How does applying some of those things and some of the people that you've quoted before, how does your model rely on sort of local knowledge and local price signals in ways that large systems can't address, really? Again, going back to the rural area, that's a very different market than a big city in terms of pricing and all that. So how do you deal with those things at a local level compared to when you go to a rural area versus serving, the Philadelphia area, for example?
Yeah, so we have a couple of sources that we can go to kind of compare what things should cost in different areas. There is a database that we have access to that takes Medicare data and cash data and all that stuff, especially, over the last couple of years where price transparency has become so important and mandated, really.
Yeah, talked about, but not really implemented very well.
Right, not implemented well at all. But it's actually, sometimes it's very hard to find, and it took me a while to find it as well. But every hospital system has to advertise their cash prices. And it's funny, it's like buying a car, they tell you like, oh, it's $50,000, but if you pay cash, it's $35,000 or whatever.
Yeah.
But,
yeah.
Most hospital systems are similarly priced, even in different geographic regions. There is variability, but they're similarly priced. And I think because things are really inefficient at a hospital and they have a lot of overhead and they have a lot of administrators that they have to pay. But there are databases that exist that will give you Medicare data and local data. And we use those prices as well as, looking at the other facilities. Even though there aren't that many facilities that are doing it across the US, we still have to be reasonably priced compared to those other facilities, because at the end of the day, patients do have a choice that they can travel to those other places as well, right? So if
Sure.
another place is significantly cheaper, they'll spend the money to travel. Although, again, there is something to be said about getting your care locally. And sometimes that does involve paying a little bit of a premium, but we have to stay within range. And it's an interesting question because everybody that I've spoken to in this space is very open to sharing their ideas. Nobody's like hiding anything. Nobody's saying like, oh, this is proprietary and I'm not willing to share. Everybody that believes in free market economics and free market healthcare realizes that everybody gains when there's competition. And that's the key to reducing the overall cost and to make this successful and to really change everybody's mindset about how we pay for insurance. And everybody's very willing to share their data and their ideas. Nobody has said like, oh no, like we don't want competition. So, I'll go back to Keith Smith. He's been a tremendous mentor. Anytime I had questions along the way of building the company, he was very open to sharing what he's gone through or how he has his model, or, here, take our books of like how we operate, right? Like all the legal framework and all that stuff. Like there's nothing to hide.
Yeah, and that on this side of the equation, that makes sense, right? Having been involved in legislative fights and stuff here in our state, the other side of that equation, i.e., the status quo or the incumbents of whatever system is in place, obviously have a vested interest in things not changing, right? So the price transparency that you mentioned, even though the hospitals are required legally to offer that, if you as a patient try to find out what that price is and you go to their website, it's indecipherable.
Yeah.
Right. I mean, on purpose, it's indecipherable.
Right.
It's basically wear the patient out until they just quit, So
right.
The model itself, you actually fly into a location, right, that you have a contract with or a relationship with that you've established. The payment then is, I guess, as frictionless as it can be, right? It's really you providing the service, the patient or the employer on behalf of the patient, right? And then the facility and their supplies and providers and all that kind of stuff, right? How does that get managed? I mean, from a financial point of view, how is the transaction? Is there a contract between all the parties?
No. So another pain point that I think patients have with the traditional model that we have currently is that they get multiple bills from multiple sources, right? So somebody gets a surgery at a hospital, they'll get a bill from anesthesia, for example, right? And then obviously, most of the time they'll fight it and they say, we can't afford it or whatever. Then they pay whatever it is that they end up negotiating. Then 3 months later, another bill comes in. It's the facility. And patients don't know what that means. And
right.
They're like, we paid this already. And they're like, no, you paid anesthesia. This is the facility.
And then there's the pharmacy.
Right. Then it's this. Then it's the surgeon. Right. And they get all these bills. So that's another pain point that this model does away with. So that's what I mean by a bundled price. So we give the all-in price. So say, for example, off the top of my head, gallbladder, for example, let's say $10,000. That's all in. That includes anesthesia. That includes the facility. That includes the surgeon. That includes the post-op care. And the patients or the employer will not see another bill. The payment is made ahead of time, and that's it. They don't get those pain points that they normally do. And we, as a company, then distribute those funds to wherever it needs to go. So we do that all on the back end because we want the thing to be as seamless as possible for the patients.
Right. Which again is an Austrian principle, right? The friction cost collapse.
Right. And this all comes down to freedom, right? Milton Friedman had a book, Free to Choose, because the underlying principle of all this is that the patients and the physicians should have the freedom to choose their path, right? As long as it doesn't interfere with others' lives, they should be able to choose what they want. And this goes back, you mentioned Austrian economics a couple of times. It's really funny because I sit on a couple economics committees for like national organizations, for example, like the AAST, which is a trauma society, or TCAA. And you have some really smart people in the trauma world sitting around the table trying to figure out how to increase value and decrease costs. And, everybody's like, oh, well, it all comes down to quality or this or that. And the truth is, a basic premise of Austrian economics is the assignment of value is a very individual thing. And we as physicians can't assign the same value that the patient may assign to what it is that they're purchasing.
Of course.
And when you give the choice back to the patients, they can make the calculations that are necessary for them to decide where they want to spend their dollars. And right now with traditional insurance, they don't have that choice. And like I said at the beginning, the doctors don't have the choices. The patients don't have the choices. Everything is very narrow in terms of what they're allowed to do.
Yeah, it's interesting because, as you know, part of my practice is elective cosmetic, which those patients come in expecting to pay out of pocket, expecting a quote for those services that is all in. Specifically, I'm not going to see another bill, right? This is all in, just like you described. But the other more interesting thing that backs up what you're saying is those patients who have insurance, who are insured, and then they come in for a service that may traditionally be covered by insurance, right? For what I do, removal of skin cancer or a variety of other things that traditionally they would just bill their insurance company. But their deductible is so high that they want to know, if I pay you out of pocket, how much would it be? And it becomes a no-brainer for the patient. I mean, when they understand that their premiums, they're paying so much more for the privilege of using insurance than if they just paid out of pocket, they'd have more cash in their pocket, So it's interesting. We see this every single day when the patients have a choice they make a value judgment, right? They decide, is this worth paying X or, do I pay Y? I mean, or they shop, right? I mean, they compare.
Yeah. And, like a lot of people think that medicine is different than any other good or service.
Yeah, it's not.
The truth is, it's exactly the same.
Right.
Just like you go shopping for a car and you decide how much you want to spend, right? And you can spend a lot of money or you can spend a little bit, and you already know quality, right? Like quality is known in that field. And the same thing, medicine, it's the same way that quality of cars, right? It's other people's experience and word of mouth. And it shouldn't be regarded as something different, right? Like people will make so many arguments like, oh, well, you don't have all the information. And no, like especially nowadays with the internet and like social media, patients come in very educated and know what they want and expect a certain level of service. And you can pay for that. And like you mentioned, in your field in plastic surgery and in LASIK surgery, for example, we do have examples in medicine where paying cash, paying out of pocket has reduced costs and increased quality over time.
No question.
Right. There's no better way to do it than to pay directly.
Right.
And I'm not against insurance, but you have to use insurance the way it was intended to be, which is to not bankrupt you for something catastrophic and unexpected.
Right.
But for routine things, and I would argue that, if somebody needs their gallbladder out, that's a once in a lifetime event. It's $10,000. Yes, it sounds expensive, but I would argue that most people, if they had some fund that they kept for medical necessity, they would be able to afford that. And the way I know it is because most people who would be considered middle class or even lower have cell phones in their pocket that cost $1,000 and they have a new one every 2 years, right? So, if you tell them, look, you got to get a colonoscopy and I know cash colonoscopy is $1,200. That's a once every 10-year event. If you have a cell phone that's $1,000 and you buy a new one every 2 years, you should be able to afford a colonoscopy every 10 years for $1,200, right?
Right.
Or to have a primary care physician, like concierge type medicine that costs, I don't know, $500 a year or whatever on a monthly basis. Most people can afford routine things. They just got to make it a priority.
Well, I think also, in all fairness, people have gotten used to and accustomed to, but also don't realize there are alternatives, right? So you get employed, you now have a quote health benefit from your employer. And basically that's where it stops, right? I mean, a lot of people can't afford to buy additional insurance or put money away in an HSA and all that because they're actually making X less than if they had that money on their own. But I mean, that's a big, huge systemic problem that we're not going to fix today. But one of the things that I was going to ask you is, do patients choose ACES, or are the ASCs offering that as a service, or the hospital? Sort of how does the consumer, i.e. the patient, the employer, choose ACES for their gallbladder, so to speak?
So it depends who they're being referred to. Like ideally, they'd be referred by a primary care physician who we have advertised to, or we have a relationship with, that when they have a patient who needs their gallbladder out would say, hey, you know what? I have this group of surgeons who can do this. Same thing with the employer. There is one facility that we work with in Wisconsin that's already set up like the Surgery Center of Oklahoma. So we're their general surgery provider. So when a patient gets referred to them, they say, yes, we do have general surgery. Our surgeons are ACES surgeons.
Right.
But ideally, we would be like any other practice where, again, there isn't really anybody like us that does the same thing. We want to get to a place where patients are in this space where they would be paying out of pocket one way or another,
Sure.
that they would say, oh, you know what? I know that there's this company called ACES. They can do the surgery locally. Let me give them a call.
We'll be right back after this break.
If you are a physician or an administrative professional working in a medical field in South Carolina, we invite you to consider joining the IndyDocs membership. Members have access to exclusive resources and networking opportunities and are an essential part of supporting our mission to preserve, protect, and promote the practice of independent medicine. For more information, please visit our website at indydocs.com. That's INDEDOCS.com.
Let's talk a little bit about the medical side of this. So traditional medicine, I see a patient in person, I do a consultation, I evaluate what they need. Again, a little bit different from urgent stuff, but there's this physical interaction, that establishes the relationship, surgery scheduled, et cetera, et cetera, et cetera. How does that work with your model where you are in one state and the patient is another state? And sort of talk to me about the whole process of how that patient gets engaged with you once they know about you, but how do you then establish continuity, all the medical parts of this?
Sure. So we have an administrator or administrative assistant who's sort of like the office assistant, right? But everything's virtual. They would get the phone call or the referral. We would set up a telehealth visit, just like, almost like a Zoom call with a doctor. And I think it's become more accepted after COVID. But in reality, some of this data stems back to like even before I was a resident. The truth is, we grew up thinking that the physical exam was like such an important thing, which I'm not discounting a physical exam. But the truth is, there's so much variability, right? And the signs and symptoms could be so variable. And with today's imaging technology that's so high definition, there's very few surgeries that I can't do without preoperative imaging. So I'll give you an example. The most common procedure we do is hernias. On every patient that I do a hernia, I want preoperative imaging, even if I was to see them in person, because if it's an inguinal hernia, I want to make sure that there isn't one on the other side that I got to take care of at the same time, or I want to know the size of the defect, right? Because especially when you're running a lean operation, we don't just have like a stack of different size meshes. We want to be able to know ahead of time, okay, what size mesh am I going to use? So the imaging is very important. And the imaging now, obviously, I can just see online. And what we found actually is that patients prefer the telehealth visit to a traditional visit. They don't mind the fact that there isn't a traditional physical exam.
Just to interject, they actually have had that with their local physician, right?
Correct.
I mean, you're getting consulted as a secondary specialist.
We do have patients who are self-referred.
Okay.
But even if they were referred by a primary care physician, there are times that we get a referral from a primary care physician for, an inguinal hernia, and then we get a CAT scan and we don't appreciate the hernia. And we tell the patient, like, look, the truth is that we don't see it on imaging. And if there isn't evidence of that, then, we're not going to do the surgery. Or if they're really convinced that, okay, it's something there, then we could say, look, we're coming to your location on this and this date to operate. If you want, you can come in one day. We'll examine you in person on that day and then decide either same day or for the next day that you'll have an operation. But that's very few and far between. But the patients do prefer to be seen in a telehealth visit. We see patients on the weekends because of it. We see patients during work hours at work. Like I've had many patients who on their 20-minute break at work go into the break room and see me, and they didn't have to drive a half hour to the office, and they didn't have to wait a half hour because I'm running late, and it's very convenient for them. A lot of them just say, this is so convenient. I literally get on my phone, talk to my surgeon for 20 minutes. We've already reviewed their imaging usually before we see them, and we schedule surgery on the spot. So the process is very convenient for most people.
And then how do you think about continuity of care after a surgical procedure, potential complications, management of complications? Tell me a little bit what your protocol is for those things.
Yeah, so most people don't have any complications, right? Then there's a small percentage of patients that have a complication that can be handled by their direct primary care physician. And a very, very small percentage of the overall patients would require some kind of intervention either at the hospital or by another surgery. So we have encountered the spectrum. Again, most people don't have any issues. The few that did went to the primary care physician.
And you have a relationship with the primary care person already, right?
Correct.
You as a surgeon.
Yes. So everybody who refers patients to us, we have a relationship with. Usually we even met them in person when we came into town. Like we usually have like a networking dinner after the day of surgery. So we know them. We provide like post-op letters of like what we did and management. Or if there's a complication, we reach out to them directly to say like, hey, can you help us get post-op MRCP or something like that. And then the few that needed a little bit more, we had a patient who had a leak after a gallbladder surgery, had to go into the hospital, got the usual care, didn't require any more surgery. They just needed a gastroenterologist for an ERCP. So that's something that we couldn't have taken care of anyways. We had one patient who needed a revision of a scar that we just booked for the next time we were local.
Right, but what about acute hematoma or a perforation? One of the serious complications. How does that figure into your?
Yeah, so patients usually have a traditional insurance product in addition to what they normally have from their employer, and they seek care at the local hospital. And this is not any different than what traditionally happens, right? Especially for me as an acute care surgeon, right? I see patients coming into my ED and having to take care of them if they had a complication from another surgery that somebody else did, right? It's sort of the model that we've gone to in 2026. And for years now, many patients go to a local ER that may not be serviced by the surgeon that operated on them.
Right. But again, to play devil's advocate, you and I know that in those situations where we've been called in to fix somebody else's problem, there's a little bit different tenor or flavor to that atmosphere than you taking care of your own complication, right? So how does that factor? And I realize these are very small numbers of cases, but the bigger you get, the more of those are going to happen, right? So how do you kind of plan for that moving forward, or how do you think about that?
Yeah, well, you make a good point, because as we grow, ideally, we would have a presence there on a weekly basis, right? So right now, because we're small, most facilities that we go once a month for just a couple days. But as the volume grows and as more people realize that this is probably a better way to go, we would have a presence every week. Now, it may not be the same exact surgeon,
Sure.
But again, all this stems from the philosophy of acute care surgery, which is a teamwork type of model, right? Like trauma, where yes, it may not be the same surgeon, but we're all part of the same team and we all practice very similarly. And even though, this was Dr. Smith's complication, the next doctor coming in is his partner.
Right.
They're in touch. They know exactly what they did. They'll be in touch, when they operate, and the continuity of care is there, but in a teamwork model.
Yeah, that makes sense. Yeah. How do you choose the members of the surgical team? Or tell us a little bit about who's actually flying in and out, or is everybody flying in together, or is this all private plane? Is this commercial? Is this?
So right now, we don't have the volume to support private aviation for everybody. Obviously, for me, it's very convenient and I can do that. If we have a pilot surgeon who's willing and able to do it, then yes, we do have some physicians who can do that. But most of our physicians right now fly commercial to the location. So it is, in a sense, traditionally like a locums model. The vision is that eventually, when we get big enough, we will have a certain number of aircraft positioned strategically across, to start, the eastern half of the United States, within a very short driving distance for any surgeon to get to hop on board and to be flown somewhere. From an economics perspective, I think the most economical platform would be like a single engine turboprop. And, again, for those who are like the naysayers, this is actually not as far-fetched as they think. Like, again, I've been doing this for over 12 years now, flying myself to different places, and it can be reasonably done.
So the surgeons that you have currently affiliated, what specialties, or tell me a little bit about what you're able to offer, currently.
So I have both general surgeons and orthopedic surgeons. We have not branched out completely into orthopedic surgery right now because the majority of the business is in general surgery. And again, as we grow, I'd like to add other specialties, but I have to make sure that the volume is there. I'd love to be able to offer like GYN and ENT and maybe even, GI for scopes.
Sure. Yep.
Today I spoke to a facility that needed interventional cardiology, right? So I'd love to be able to offer all those things. We just have to make sure that, it's worthwhile to travel somewhere for a certain number of cases, and we have to figure out what those number of cases are. But right now, the majority of the cases we do is general surgery. And the general surgeons that I have obviously are all board certified, usually have an acute care surgery background. Again, they have that team mentality. Most of them have like a military background, right? It says a certain level of excellence that they have and that we seek. I've had a couple people reach out who are either in residency or fellowship, but the truth is, like, this model is not made for people who are just coming out of fellowship. Like, they need to have practiced for a number of years to hone their skill because, you're really a one-man show when you're there. So,
yeah, so that makes sense to me that somebody right out of training, this may sound kind of glamorous, but you need to have some sort of level of expertise to go in and do a gallbladder and know that your success rate is pretty good rather than still learning or what I mean, or expanding your experience. But so how do you find people who are, I guess, culturally fit for what you're doing? And
yeah, so believe it or not, the majority of the surgeons that I found were from LinkedIn.
Interesting.
We check out their credentials. Usually they're like affiliated with a university. Like I said, most of them have acute care surgery background, military. They may have experience already doing locums, so they understand the model of traveling. It's a small world, especially acute care surgery. Usually I do a background check, seeing who they're connected with, where they've worked and all that.
Sure.
And then we do the usual credentialing, right? Like if they have any malpractice cases and whatnot, obviously, like what we do is we cover malpractice. So that's something that we have to know about. And we have to get them credentialed at every facility. So all the usual stuff that you have to submit to credentials. But, just because you're part of the team doesn't mean you stay on the team also, right? So it has to be a good fit. You have to make sure to really be detail oriented. It is an independent contracting model, so it's not like a traditional employment model where, okay, you know what, if you're not cut out for this, it's very hard to fire somebody. The truth is, if it's not a good fit, it's not a good fit. And we have many surgeons who want to be part of this team. Part of it is self-selecting, like people already see, what work is involved, but I think a lot of people want to be part of it because they see and want to be independent. And that's, I think, the biggest factor for most surgeons is this gives them a lot of independence.
Yeah, and as you and I both know, autonomy and independence is a key to physicians being happy and professionally fulfilled and feel more accountable, which I guess is important in the model that you're doing as well, right? Because you're really not just flying in and flying out. And I mean, you really are taking responsibility for the outcome, right, that is happening there.
Exactly.
What forms of resistance to this model did you expect, not expect, actually experienced? Because I'm sure that anything that's a little bit disruptive, is going to have somebody on the other side of the equation that doesn't think this is so great for them.
Right.
So what's the resistance?
Yeah.
Or is there?
So luckily, I've been surrounded by a lot of people who love the model and who have a similar mindset. But as you can imagine, the biggest resistance for everybody in this space, including myself, is the traditional providers of healthcare, right? So like hospital systems, insurance companies. Not that I've had any experience with governmental organizations, but them as well. Like they have a very, like you said it earlier, there's a very large interest group whose vested interest is to continue the status quo. And now there's a lot of people who are disrupting that, still a minority.
Right.
But I believe that within the next 10 to 15 years, the bubble's going to burst, and this will be the way healthcare gets delivered across the board. I think we're seeing changes in DC right now, and the mindset is shifting there that the traditional healthcare insurance model is not working for anybody. And there's legislation passing that allows physicians to be independent. For me personally, the biggest resistance is just from traditional corporate healthcare, corporate hospitals. And it's funny because it's like we're not even competing for the same patients, right? Like these patients don't have the traditional insurance. They're in states that are far away from where I work traditionally, but still it's becoming an issue. And can't get too detailed on that, but I think obviously the traditional players, healthcare systems do not appreciate this.
Again, going back to a comment earlier, I think this really has the potential to positively affect rural access. I hadn't thought about that until we started talking today, but I really think that is a niche that everybody talks about, but there aren't any really easy solutions. And this actually is relatively easy to implement. If you already have a hospital, small community hospital there, they're all struggling for a lot of reasons that have nothing to do with what we're talking about. But this is an opportunity really for them to retain local patients, provide a service that they may not be offering or not offering very well, and provide a workforce that isn't intuitively available there. A lot of people just don't want to live there,
Yeah, I gave a talk, I think it was back in October, about the evolution of ACEs. And that's actually 2 slides that I showed back to back. One was I showed rural hospitals across the US. So I showed a map of the US with dots for every rural hospital. And then I overlaid it with a map of general aviation airports. And they almost match, right? So the reality is that we can fly into pretty much any rural facility. There's probably an airport that I can fly into within a 15 to 20-minute drive.
Right.
And in fact, again, that's what I've been doing for the last 12 years. I fly in from an airport 15 minutes from my house to an airport 15 minutes from the hospital I work at. And it's fairly rural. And even the rural facility that I'm at has satellite hospitals about an hour to an hour and a half away that feed into this hospital that's even more rural. Right?
Sure.
So yes, and again, they would normally not be able to have the coverage that they need.
Another sort of route of patients, other than the locally available patients in those areas, is that those people work for employers that may find it more cost effective or certainly a higher value to have them operated on in this type of setting, a cash, So have you reached out to employers, about direct to employer contracting or through some TPAs, to try to show employers that this is an option? Not everybody knows about the Surgery Center of Oklahoma, though.
Yeah.
But you're offering a mobile version of that.
Yes. Yeah. So, we haven't been in existence that long. We started operating on patients in November. But over the next 6 months, we're going to like all the national meetings for employers, shopping around for health plans, TPA conventions to make those connections.
Sure.
We're also just going directly to employers. So, in the states that we're operating in, just reaching out to the employers and saying, hey, can we talk to your benefits office? We'd love to show you guys what we do, give you a presentation, and see if we can save you money.
There are thousands of small to mid-sized businesses in every state, really. And many of those are self-funded, and they, I think there's a trend towards employers looking at self-funding because of all the financial pressures that we've already mentioned. But it seems like that would definitely be a source of potential growth in convincing the employers to have their employees' surgical care managed this way rather than them driving to the major cosmopolitan area and going to the academic medical center, for example, and
Right.
and all that entails. So interesting. In terms of imaging and all that, do you rely on the primary care, or do you have independent imaging centers that you have established relationships with? Sort of, as you said, some patients go to you directly. So if they need an ultrasound or a CT or something, how do you then manage ordering that and having them get the imaging that you rely on?
Yeah, so when we first started, we relied heavily on the direct primary care physicians because they knew where the imaging centers were that were favorable to this kind of model, where it could get a cash price and pay reasonable prices. And then over time, we just formed direct relationships with those facilities so that if a patient does come to us directly, we can refer them to that facility locally and say, like, look, you can get your CAT scan couple $100 at this facility. And so when we go to a new location, again, we find the local facilities where we can get that done so that patients can get it within the same space.
How long does it take you when you identify one of those dots on the map as a potential center for you to actually implement saying we're flying in to do a case? And how many cases do you have to do to sort of make this worthwhile economically? And the follow-up to that would be is how do you measure ACES success, not on a medical point of view, but really as a business?
So if all goes well, we have the infrastructure now to get up and running, assuming the facility has the equipment and all that stuff, because sometimes getting the equipment is the limiting factor, but we can do it as quickly as a month in a new facility.
Okay.
Although you didn't ask it, I will say that once we're also up and running, from initial consultation to surgery, we can do it in as quickly as a week. So if a patient reaches out to us, we can get their surgery done very quickly as well. Regarding the success, I'd love to see this in all 50 states. Obviously, again, like you did ask, how many cases does it need to be to make it worth our while? It really depends on the type of cases. The truth is, from a business development standpoint, like sometimes we would have to go somewhere even to just do one case to show proof of concept and to get the word out. And we're willing to make that investment because once one patient has a good experience or one employer sees that, hey, these guys are the real deal, then, the business will come. So there isn't really a specific number, but ideally we would love to operate everywhere, right? We're mobile, so it doesn't matter where we go.
So you could actually, if you identified a key location, again, in a particular geographic area, that ASC or even that little hospital could become almost a destination for surgical patients, right?
Yeah. And in fact, we've had facilities reach out to us also in what are fairly major metropolitan areas that are interested in working with us. So it can absolutely be a destination type practice where, like I said before, patients are traveling from all over the US to the Surgery Center of Oklahoma. We're now offering a similar service in other cities that patients may prefer to go to. Like just today, I had a conversation with an ASC in Miami. We already are set up and ready to go in Charleston. We're on the shore of Connecticut. We have a facility in Wisconsin on the lake. So some of these places are really beautiful places to be at. And again, some patients may say, you know what, I'd like to have my hernia surgery and make a weekend out of it with my family and spend a weekend somewhere where they can enjoy themselves while I recover. And, going back to your question about where we see ourselves, I'd also love to see Canadian patients come down as well, right? Like Canada has major problems with their healthcare system in terms of wait times.
Sure.
Like I said, we can do surgery within a week. So I hope to also get a share of the Canadian market. As you know, many Canadian patients seek care in the United States for that exact reason. And they're already paying cash for their surgeries. And again, we can offer that at a fraction of the cost of what it would be at the hospital.
So what are the next steps in terms of the company's logical expansion, or like what are your sort of your immediate goals here? Obviously, you want more people to know about you and employers and all that, but just in terms of reach and number of doctors, or
Yeah.
sort of tell me a little bit about how you envision seeing this as a company, right?
Right. So right now, our goal is to just get a constant stream of patients to go to all of our locations where we're already set up. So Wisconsin is already set up on a regular schedule. We set up a facility in Connecticut and in South Carolina that I'd like to see at capacity. Just today, I had a call with a facility in Austin and, like I said, a facility in Miami. We actually have a list of surgeons who are sort of on a wait list that as soon as we have the volume that we can activate them. So that's sort of the stepwise progression is get Connecticut and South Carolina operating like Wisconsin, and then expand into markets like Austin, like Miami. I would love to be in Nashville and, like you said, maybe even rural areas. And again, we have the ability to come to a facility within 15, 20 minutes of an airport. So it's very easy for us to start the operation.
Yeah. In South Carolina, I think that there'd be a real opportunity there, because just from knowledge of what's going on in the legislature, and we're a small state. So literally you can fly from one end to the other in 30 minutes. I mean, it's multiple little stops along the way, and it would fill a real need. Is there a website? Is there literature out there? Sort of, I'm a patient who, wants to have my carpal tunnel fixed, and I hear that you can come to Charleston and do it. How do I do that?
Yeah. So you can find us at acessurgical.com. That's ACES surgical.com. In there's going to be a tab for patients. There's also a tab for doctors or facilities, but basically there's like an intake form. You could fill out the information. It'll send us an email, and we would reach out to you if you need surgery and start talking to you about what it would cost, where we would offer it, and the timeline and all that. Super easy process.
So that's how patients get to you as a referring physician. How do I access your team or your services?
Yeah, so you can reach us directly at support@acessurgical.com, and our email is HIPAA compliant.
Great.
So you can send the patient information if you'd like, and then our team will take over and reach out directly to the patient to set everything up. Or if you're an employer and you want to partner with us, you can also use that email to reach out to us, and we will make contact. Every one of our patients has said that it was just an experience like they've never had before, right? They never thought medicine could be like this, but this is what they expected medicine to be.
Yeah, so some years ago, the Department of Labor and Statistics came out with this graph of the 6 things that most people talk about at the dinner table. And it doesn't matter what level income or what level strata you are part of, but transportation, education, housing, entertainment, and food are the 5 things that everybody talks about, but everybody has control over. So if you look at those 5 things, families, individuals will regulate how much they spend on each one of those. Want to go on a vacation, so we're going to spend a little bit less on going out to dinner, or we're going to, want to send the kid to private school, et cetera. So those 5 things, we all manipulate. The one thing, the 6th thing that everybody talks about but has no control over the pricing is healthcare. And if you map out how much those costs have gone up, everything else gets up and down by X percentage because we control it. And healthcare just kept on going up and up and up and up and up. So I think what you're doing is actually adding some control as an alternative, to individuals, to companies, to employers, to actually be able to have some say in addressing that cost. So that's, I think, terrific. I think that's amazing.
Thank you.
Well, on that note, I really want to thank you for joining us on our podcast. I really think you have a tremendous idea, and I think it's going to be very successful. Again, it's based on solid things that will make a difference. Is there anything that you think would be helpful for those who are interested in the basic principles of what informed your thinking about this model and just all the things we've talked about, healthcare and who pays for what and that type of thing.
Going back to all the talk about economics, for example, a book that I recommend to everybody is Basic Economics by Thomas Sowell. I think anybody who has any interest in economics in general and healthcare economics in particular should read that book. It's a very thick book, but it's actually a very quick read, and it'll totally change the way you think in general. It just goes through the layers that a lot of people miss when they think about a solution to something or why something happens. Usually it's like a first or second order thinking, and this kind of takes you deeper to understand something on a different level. So that book was instrumental in my evolution into this space. It helped me think through a lot of different problems very differently than I would have before.
Great. Apart from your website and email and all that, are you on any of the social media platforms? Or if people wanted to follow you in terms of your writings and information, where would you direct them?
So I'm on LinkedIn. I post regularly. Sometimes I post my articles, and I'm also on Instagram. Instagram is actually very interesting because I have some videos where you see like a day in the life. You could just find me at Ronen Elefant. We also have a YouTube channel for ACES. It's in its infancy, but we do have some patient testimonials there so you can hear the patient's perspective.
Great. So again, Ronen, thank you so much. And I look forward to continuing this conversation offline and in person.
Thank you very much for having me.
To everyone listening, thank you for joining us. Please make sure to rate and follow the podcast, as that really helps us to grow this community and spread the word about the issues we've explored today. Also, please tune in next time for another great discussion about independent medicine in South Carolina. From all of us at IndyDocs, take care and stay well.
Thank you for tuning in to this episode of the IndyDocs podcast. Our producer is Jenna Leaf. Promotional support by Uplift Marketing. Mixing and mastering by Noah Martin. Content editing by Jenna Leaf. Additional production support by Noah Martin, Rebecca Lockhart, John Robinson, and the IndyDocs Board of Directors. For more information, please visit us online at indydocs.com.